The next speaker is Dr. Leila Mohan. Madam is a senior pediatric ophthalmologist and cataract surgeon and at Comtrist Hospital, Calicut. She'll be talking on investigating pale disc in a child.
Now, coming to the another dilemma, when you have a pale disc, you want to know whether it is genuinely pale or not. So, pallor is a morphological sequel of damage to retinal ganglion cell and axons along their course from retina to lateral geniculate body. It's due to the loss of ganglion cell axons, reduced vascularity, gliotic proliferation, increased visibility of sclera, and there is an overall reduction in size of the optic nerve. And retrograde axonal regeneration in posterior visual pathway due to perinatal trauma can also lead to pallor. About 30% of children with multiple disabilities like CP, motor developmental delay, they have pale discs. And pathology may be degenerative, ischemic, inflammatory, traumatic, demyelinative or compressive. Optic neuropathy is a better term than atrophy. The causative factors have changed over the last 50 years due to diagnostic challenges accounted for not finding a causative factor in a good number of cases before the advent of the investigative imaging modalities. And in the 60s, it was inherited conditions was considered to be the commonest. In the 80s, brain tumors, and now complications of premature birth and perinatal insults account for a good number of these cases. So a good workup, visual acuity, field, color vision when possible. Signs and symptoms of visual loss including field is not easy to elicit in a very young child, and methodical clinical examination including a family history of similar vision loss, including a pedigree chart, birth history, pre, post and perinatal insults, seizures, hypoxia, developmental history, trauma, exposure to medications or toxins are all important. And pupil, examination of pupil is very important. OCT of the disc and retina can point out the distribution of loss of RNFL, whether it is progressive over time. FFA and autofluorescence and electrophysiological tests rule out any retinal pathology and neurological evaluation with VEP and of course MRI. So coming to the examination of the disc, the shades and distribution of optic disc pallor are to be noted. As you see here, you can see temporal pallor which may point to a hereditary or nutritional deficiency or a post-neurotic pallor, and peripapillary indistinct margins and gliotic tissue may point to a chronic papilledema, and bow tie pattern as in chiasmal or post-chiasmal lesions, and consecutive optic atrophy. You have to look for any retinal nerve fiber dropout and thinning, and attenuation of blood vessels around the disc has to be noted. Some of the mimickers are myelinated nerve fibers. As you see here, optic disc coloboma, optic disc hypoplasia with a double ring appearing like a pale disc. Buried drusen is not uncommon. You have to rule it out with an autofluorescence. Sometimes even a bright light pressure on the eyes can appear as a pale disc, so the child has to be brought back again to see, especially during infancy when you forcibly open the eyes. So let us go through some of these scenarios. We cannot go through all the conditions of pale disc. So a 2-year boy with motor disabilities was referred by pediatrician for defective vision. He was fixing and following with both eyes not reaching out yet and showed pale discs. His history of prematurity and perinatal admission in the ICU and global developmental delay and seizures was there with spasticity. MRI showed volume loss and hyperintensities in periventricular white matter as you see in this picture, and was diagnosed with periventricular leukomalacia. Hypoxic ischemic encephalopathy can produce atrophic, cystic and gliotic changes also. Functional vision assessment is important in these cases, and vision improves to a great extent over time, and early rehabilitation with a multidisciplinary approach is necessary. And this is an 8-year-old boy with complaints of defective vision, tripping over when walking and poor performance at school. You can see the large cup, and he gave a history of the parents gave a history of prolonged NICU management, and visual acuity was 618 with a cylindrical correction of -180, which is not very high. and a cupping was of 0.8 in both eyes with a large disc. IOP was normal. The field showed bilateral inferior altitudinal defects, and MRI showed PVL, periventricular leukomalacia with occipital gliosis, and prenatal injury to the optic radiations with retrograde transsynaptic degeneration of retinogeniculate axons produces this picture, which was described by Jacobson in 1995. We can avoid unnecessary examination under anesthesia to rule out glaucoma in a child when this presentation happens with a very large cup, and it's not uncommon to see these due to perinatal trauma. So a 16-year-old boy, I used to do a lot of examination under anesthesia about 25 years back to rule out some of these cases, but over time you follow up, you see all these findings with an inferior altitudinal field defect. So a 16-year-old boy of studying in +1 complained of blurry vision in right eye, which was progressive over 3 days, and visual acuity was 660, 69. Refraction was normal, pupils were normal. Fundus showed mild hyperemia of the disc. Color vision was abnormal with the desaturation. Field showed centrocecal scotoma in right eye. VEP showed delayed latency, and MRI was normal. So we diagnosed optic neuritis and started him on injection. This was some time back. Injection methylprednisolone followed by oral prednisolone. After 2 weeks, vision in left eye also became blurred. And when he was on steroids, vision came down to 5/60, and it was progressive over 3 to 4 weeks. Both eyes had 360, 260. On further inquiry, many members in the family from maternal side had defective vision, the cause of which was not known. The discs showed pallor and pupils became ill-sustained. We suspected LHON, Leber's hereditary optic neuropathy, and had a neuro and cardiac evaluation. He did his exams with the help of a scribe for 2 years, and after this his vision recovered to a great extent. Vision improved to 6/9, which is very unusual in these cases. So a molecular analysis was done later, which showed 4 mutations, which as you can see here, all these numbers, 4 mutations on ND1, 4 and 6 are not the usual pattern we see in LHON. So this Leber's hereditary optic neuropathy is inherited through maternal mitochondrial DNA due to primary mutation of one of the 3 mitochondrial DNAs, and these 3 account for 90% of the cases. They present with acute drop in vision in about second or third decade, more in males, and progressing to optic atrophy and permanent and profound vision lost in most of the cases. Some patients with who had an early onset may recover, and they may have associated cardiac neurological when they are called Leber's plus. Now, idebenone, ubiquinone analog, which supports mitochondrial ATP synthesis and has an antioxidant property, is recommended since 2017 with reasonably good results when started early enough, and even up to 1 year. And gene therapy and stem cell therapy are on trial. Other medicines on trial are brimonidine, glutathione, antioxidants, all to protect the mitochondrial DNA. Genetic counseling of the predisposed to avoid neurotoxic agents. These are triggered by some of the neurotoxins. So to avoid tobacco, alcohol, and ethambutol, which to prevent the triggering of the predisposed patients. Other forms of hereditary optic atrophy are also there. Autosomal dominant mitochondrial dysfunction with an OPA1 gene mutation, and which has a slow onset during first decade and slow progression. Often they are brought during school screening, and they have central or centrocecal scotomas. Neurological associations may be seen, and idebenone has been tried, and with some good results. X-linked and recessive forms of optic atrophy are also seen, and Wolfram syndrome is a recessive condition with childhood IDDM, insulin dependent, and diabetes mellitus with optic atrophy and deafness. So molecular analysis is sometimes important in these cases. So a boy of 4 years was admitted in neurosurgery department with following RTA. And we were called to see the eye. He showed RAPD in right eye, vision was only counting fingers, and fundus appeared normal, and traumatic optic neuropathy was suspected and taken up for decompression of the fracture, and injection methylprednisolone followed by oral steroids started. Vision improved to 636 and then stayed there. Was advised patching but did not improve further. Later he developed exotropia, which was corrected later. So traumatic optic neuropathy is sometimes another condition where you have to look for the fundus very carefully for and look for any RAPD. So this is an 8-year-old child who was being followed up after a unilateral cataract surgery with amblyopia. Later we found that her vision was dropping. She was not very compliant with patching, but we on a disc appeared pale, so we did vision was down below a few meters, so we couldn't do field test in that eye. But when we did field testing, the other eye showed hemianopia and a large solid cystic mass was seen. So these are some of the cases which you might miss when you look at the, especially in a phakic eye, looking at the disc may not be very convincing that it is pale. And this child, 14-year-old, actually after a fall he had an investigation of vision, and vision was half meter, disc showed a temporal pallor, but other eye showed hemianopia, and MRI showed multicystic lesion with calcification pointing to a craniopharyngioma. He was operated on. And these are some of the tumors of childhood. And compressive lesions are also not uncommon. You have to follow up these patients for any compression and optic nerve dysfunction, and surgical intervention may be necessary. This is not an uncommon situation where there is a diffuse unilateral subacute neuroretinitis with a fundus showing thinning of the arteries, arterial attenuation, marked chorioretinal changes, and a motile nematode may be seen on fundus examination, which may respond to laser treatment. And nutritional optic atrophy occasionally, especially in an autistic child who has a stereotyped diet, sometimes present with the pallor. And pediatric optic neuritis we have already seen. A detailed history, field examination, and look for RAPD. Field examination is very, very informative, sometimes imaging and molecular analysis in selected cases, and a high index of suspicion and imaging whenever necessary. Thank you. I'm sorry for taking one.